Hello, this is Pia Duryea with the Medical Society of the District of Columbia. Today, we are speaking about adverse childhood experiences, or ACEs, with members of MSDC's Task Force on Family Violence. ACEs have detrimental effect on childhood development that impact health and well-being throughout one's life. However, ACEs are often siloed as primary care, pediatric, or behavioral health problems. Today, we're speaking with Dr. Gisela Delgado-Rosado and Dr. Allison Jackson about the impact of ACEs on health and how trauma-informed care can better patient health. Dr. Allison Jackson is the Division Chief of the Child and Adolescent Protection Center at Children's National. She has over 22 years of experience as a child abuse pediatrician, which has inspired her work as an advocate and academic for children and youth who have experienced adversity and trauma. Dr. Gisela Marie Delgado-Rosado is currently faculty at the Georgetown Family Medicine Residency Program. She's a member of MSDC, and her experience working with the task force has sparked her desire to work in education and serve the local community. Doctors?
Good afternoon, Allison. Happy to have you here and have this conversation with you.
Good afternoon, Gisela. Happy to be here.
All right, so let's start today by setting that context about ACE screening, maybe describing a little bit more that initial or original ACE study.
Sure. Well, the ACE study was performed by Drs. Felitti and Anda in California in conjunction with the with the CDC. Dr. Felitti is an internist, and I have the pleasure of hearing him speak on a number of occasions. And to hear the story of how this all started, he was treating patients for obesity. And in his conversations with those patients about the origin of their challenges with food and weight, an unexpected theme of child sexual abuse emerged, which led him and others to study their patients who were within the Kaiser Permanente system with the support of the CDC. The study included over 17,000 subjects in California, of which approximately 75% were white and approximately 75% had some college education. And they asked these adult patients about their experiences with abuse and neglect and other household dysfunction, and analyzed kind of those scores that added up for those patients and subjects. And they looked at those in combination with their health outcomes. And what the study revealed was a dose-response relationship between the number of adverse childhood experiences and poor health outcomes, specifically some of the leading causes of death. Now, this study was published in 1998, and since that time, it's been replicated with different populations because obviously this was a very kind of monolithic group of patients for the original study. And it has been replicated in diverse populations, both ethnically diverse and economically diverse. And it has stimulated more research on the physiologic and the epigenetic effects of trauma and toxic stressors on health and well-being. And so while there's still much to learn, the take-home point is that trauma is common and that childhood adversity is bad for your health across the lifespan.
Okay, thank you for that. I appreciate setting that background to really get us all into the know of how it all started out. So how should clinicians then be really using this ACE tool in children and adults?
So I am not a proponent of standardized ACE screening, and clinical screening using the ACE tool is somewhat controversial. We have to remember that the study was a population study, and even those that have come since that, the replicated studies, have been population-based studies. And so the results are population-based and not individual patient-based. And so to ascribe specific risk for a singular patient based on their ACE score is something that we really need more research to be able to implement that kind of formalized use of the tool, although we know that there are those who are doing that. Of course, we know that the more we understand about our patients, the better care we can provide to them. And there's overwhelming evidence that the adversity in childhood activates a toxic stress response that can alter neurodevelopment and dysregulate the body's natural stress response, which is impacting physical and has the potential to impact physical and mental health. So I fully support ACE conversations with patients, kind of getting to know your patient's life story and how that might impact or influence their health, their decision-making, and even their engagement with the healthcare system. And our understanding of the frequency and the impact of ACEs really is the genesis of what we call trauma-informed care, which is something that we should all be practicing because trauma is in fact common.
Love that. I agree. And I think also from, the more recent studies, it's also, I love hearing about how it helps open up the discussion between providers and patients and really improves that relationship so that we are able to get patients the help that they need. What do you think maybe some limitations to these and maybe some strengths to the ACE, using the ACE screening tool?
Sure. So, as I kind of alluded to, the formal screening for ACEs and kind of gathering ACE scores for a patient for the purpose of clinical decision making is not yet a validated practice. And then we also have to be reminded that the ACE screening questions were intended for adults. It was a study of adults. It was not a study of the pediatric population. And so for children and youth, and I'm going to speak as a pediatrician, of course, here, identifying ACEs yields that opportunity for secondary prevention, early detection of abuse, neglect, or family violence. And so by doing so, it's an opportunity to disrupt or intercede in the abuse or maltreatment of a pediatric patient. And of course, along with that comes that legal mandate to report abuse or neglect when it's suspected of children. It is also an opportunity to break a cycle of abuse for a patient or within a family. And so we know that, for example, exposure to domestic violence is one of the original ACEs in that original study. And while in some jurisdictions, exposure to domestic violence or domestic violence occurring in a household may not be something that a report to Child Protective Services is required, there still is an opportunity to help and offer help for a family that is ready to accept that help. And then I think the other part of it is that knowing a patient's trauma history may provide some diagnostic clarity. For example, PTSD in children may look very much like ADHD. And so they may carry a diagnosis of ADHD when in fact that may not be at all what it is. And yet stimulants don't work for PTSD. And so it can be helpful in making sure that we're treating the right thing or managing disease the right way. For adults, knowing a patient's history of ACEs might give some additional insight into their care as well. For example, with pain management, while it might be different, it might be more difficult for patients who have a history of childhood trauma to be well managed on maybe the usual course of pain management because their system was kind of developed in a way that makes it more difficult for traditional treatment. They may require more in order to get the same results as someone who did not have those kinds of experiences. Knowing all the details of an adult patient's ACEs may not be necessary, but having some understanding may help patients get through even exams or procedures. As you might imagine, let's say you have a patient who has a history of sexual victimization in childhood or adolescence, or even adulthood for that matter, and yet you need to do a sensitive exam. Well, that exam might be very triggering for them. And so having that, just conversation of saying, this is what I'm going to need to be doing today in order to evaluate you. And it may be helpful for me, and I want to make sure that you can get through this exam. I've had some patients that have had experiences that make exams like these very difficult. Is there anything that I need to do or to make this easier for you? Or is there anything that could make this exam easier for you? And I think we have to think about that for any kind of medical setting. So whether you're a primary care provider, an OBGYN, a surgeon, or other specialist, we have to acknowledge that there are aspects of our clinical care and interventions that can trigger our patients. And so we want to kind of get ahead of that by meeting them where they are. And then I think the other, part is that we shouldn't assume that patients understand how their experiences in childhood could be impacting their own current state of well-being. And so there is great value in the psychoeducation should a patient feel comfortable enough and safe enough to share some of those experiences with you. The psychoeducation that you can provide really should not be underestimated. And kind of coupled with that is that we shouldn't make the assumption that adults who had traumatic experiences in childhood ever received help for those experiences. So you might be that first person to direct them to help. And so, for example, you might say, today we're going to talk a bit and I'm going to examine you. And, as I said earlier, some patients may have had experiences that make it difficult to get through. And that might be just the moment when they share, well, as a matter of fact, this happened to me, and I really would prefer it if you didn't do X or if you didn't do Y. And that might limit our clinical recommendations in that moment. But there is nothing, unless it's life-threatening, that says that we couldn't bring a patient back. Okay, so today maybe we're just going to talk about it now that I know this information, and maybe we need more time to get through the exam, or you need a support person to get through this exam. So maybe we're going to use this time to explain what will take place, and then we can plan for another visit. That's creating a safe space for any patient, and it also reflects that you're listening carefully and thoughtfully to their needs, and not just going through our list of the many things that we have to get through for a clinical encounter.
Thank you. Yeah, I agree. I think us being able to open that door, whether primary care or specialist, so that we can really have that conversation, provide better care for patients, it's really what we're all striving for. My next question then is, if, we were talking about how ACEs wasn't really created for a pediatric population, is there another risk screening tool that would be more helpful for this population?
So, for the pediatric population, we should be assessing, right, for abuse and for those adverse experiences. And I should, mention, we recognize that the list of adverse experiences has grown since the original study, and everything doesn't fall under the category of abuse or neglect or family violence. And so I want to make sure that I mention that, and we understand that there are other adversities like racism and poverty and homelessness that are all have the potential to adversely affect the well-being of patients across the lifespan. That being said, every opportunity that we have to see a patient is an opportunity to detect abuse if it is occurring. And so, for example, with physical abuse, there may be things that you observe on the physical exam. You may notice something on their skin. And some of this is age dependent, but certain skin injuries in certain parts of the body lend themselves to greater suspicion, or certainly certain skin injuries that have a specific pattern of an object would lend itself to a greater level of suspicion for inflicted trauma or physical abuse. Sexual abuse, it may not be obvious at all on face value with a patient. And so that really comes with a patient sharing information. But we have opportunity to model and to ask questions, about safety of body, and, whether kids even know their body parts, the names for their body parts, and what they would do, that kind of scenario. If someone were to do something or try to do something, who could you tell? Giving them that kind of information often creates a setting where disclosure may occur. But our goal should not be for the purpose of disclosure necessarily, but it really is to assess the safety and well-being of patients. In the adolescent population, we tend to use the HEADS assessment, asking about the home, education, activities, drugs, sex, and suicide. And in the context of those conversations, using that psychosocial screening tool, certainly there are opportunities to elicit experiences that may have been traumatic. There is also another tool called the SEEK tool, SEEK, which is a parent questionnaire to screen for certain psychosocial problems, such as parental depression and substance abuse. And we know that parental mental illness or exposure, or having a parent with substance abuse disorder, were actually in the original ACE studies. And so those are also, that is another tool that certainly can be quite helpful in assessing for ACEs in the pediatric population.
Thank you so much for that. Definitely learned something there about the last screening tool that you mentioned. That's super interesting and helpful for our patient population. So is there any, going now into talking more about resiliency, is there any resiliency screens that you think are helpful?
So there are there's a lot of new novel discussion about resiliency and positive childhood experiences, and even some research that's come out of that. And so what we've come to learn is that positive childhood experiences mitigate the effects of ACEs, which may explain why the outcome of ACEs can be so variable on an individual patient basis, and why the ACE reading tool alone may not be the best and only way of evaluating patients for these risks. And so asking about family strengths and giving positive feedback, it's not a tool. These are more, this is more guidance for conversation. And kind of the reality is, wow, you have a lot on your plate. How are you making it work? I continue to be amazed by how families are able to be so successful despite their circumstances. And sometimes they just need to hear that. We all benefit from positive feedback, and sometimes going to the doctor can be like nothing but bad news. And so I think it's really good for the relationship between patients and their providers to hear what they're doing right, and not just what's going wrong. There's some work out of Tufts University. My colleague, Dr. Bob Seege, and his colleagues really looked at positive childhood experiences and created what is called the 4 building blocks of hope. HOPE standing for healthy outcomes from positive experiences. And those building blocks, the first is relationship with family and with other children and adults. So asking about those relationships, who lives at home and where, who supports you and who helps you out when you need a break, those kinds of questions. Certainly, the second being safe, equitable, stable environments for living, playing, learning at home and in school. And the reality is that safe and equitable and stable environments are far and few between for so many patients and families. And so I'm asking about that and how they manage that. Um, and then engagement in social and civic activities, which gives people a sense of belonging and connectedness. And these are all things that build uh, resilience and create positive experiences. And then the fourth is emotional growth through playing and interacting with peers for self-awareness and self-regulation. And we know that children learn how to manage, crisis intervention, or excuse me, not crisis intervention, conflict resolution starts at the playground, right? Learning how to do that. It doesn't start in adulthood, even though many of us are conflict averse still in adulthood. The reality is that those skills can, begin to be managed and learned and refined in childhood. And so that is that kind of fourth component of those four building blocks. There are some family protective factors that can be identified and elicited and championed even. So even parental resilience, when you learn about maybe some of the challenges that a parent has experienced, whether it was in their childhood or in the present, knowing what their, how they've overcome that and how they're managing through that, their level of social connectedness, and their knowledge of parenting and child development. I can't speak enough as a child abuse pediatrician about how a caregiver's lack of knowledge and understanding about child development can create unreasonable expectations and create a risk for maltreatment. And then what are the concrete supports? There's a lot of research that's come out about how mitigating having the basic needs met can be for family violence. And so, when people are not having to struggle and figure out where the next meal is coming from, or if they're going to be able to pay their rent and stay in their home, that makes a big difference. It is protective for people to have kind of their basic needs met. And so those kind of identifying and exploring those protective factors with families is also kind of one way of assessing for and cultivating resiliency in families.
Thank you for that. I agree. I think it's so important the role that we play in trying to get this little neat bit information from parents so that we get to understand, is it something that we can help them develop with their kids, an activity or something to help them out, and also screen for those other factors that we can help with, right? That we have those resources for in the area and in the community as well. Moving back again to ACE screening, is there a way that clinicians can use ACE screening in adults with also co-occurring interpersonal violence?
Yes, I think we have to always put safety first, and know who's in the room, right? So some of these conversations may not be suitable for a discussion in front of other individuals. It may be suitable only for the patient or a single caregiver. And so think safety first when asking questions or trying to have this ACE conversation, if you will. For children, asking them about possible abuse or neglect is an important thing to do, but you have to be cautious about asking those questions in the presence of their caregiver, because epidemiologically, the caregiver may very well be the person who's causing the harm. And so we never want to put a patient in that awkward and uncomfortable position of trying to either avoid or answer a question without really answering it because of who's in the room, or having to tell something that is not true because of who's in the room. That really does help no one. And so sometimes it requires some teaming within your own staff to figure out the best way to do that. Again, asking about IPV or domestic violence is something that I would not encourage someone to do in front of the children. If you're asking the caregiver, again, this is a question that you would want to ask someone in private, so that they can feel more comfortable answering if they are ready to answer that question. And I think we have to acknowledge that sometimes people are not ready yet, and we cannot force that. The other thing that I want to mention when we talk about domestic violence that's co-occurring is that we have to be really cautious about how we document in the medical record our screening and any positive screens. Certainly for children in households with domestic violence, the person who uses harm may also be the parent who has equal access to that child's medical records. We know with the 21st Century Cures Act that people can access their records. I know that there are some programs who use code words for domestic violence, so it's not obvious. There's also options of having confidential notes, which at least in the immediate may not be accessible, although often any and all records can become accessible through subpoenas and other mechanisms. And at the same time, this shouldn't be a deterrent to having those conversations. We know domestic violence is all too common. We know that there is a co-occurrence of domestic violence and child maltreatment. And so we should not be selective of who we're asking. We should be universally asking about domestic violence. And when I say universal, that means it's not just females that we're asking the questions of. It's not just those in relationships with the opposite gender. We should be asking these questions across the board because they happen in all kinds of relationships, including with teens. And so as we ask that question, and those questions, we also have to be mindful that we can't force someone to tell, even when you really feel strongly that, like, I know something is happening, and they're not telling. It takes individuals about 10 times, I think, to leave a relationship. And there's a lot that they are, an individual survivor, it may be contemplating and considering in that decision making about whether or not they should or can leave, or the best timing to do that. And they know their situation best. And all that we can do is create an environment and a relationship that helps them understand that we're a safe space for them to share, and we're a space where they can get help if they desire it.
Thank you. I love how you described that importance of keeping that confidentiality for patients and really just leaving the door open for them for when they need to, because I think sometimes we know or we sense that something else is going on, but it's up to the patient to feel comfortable sharing their story to then kind of help them move forward. And just always leaving that door open is so important for everything that's going on for them to provide better care. So now that we've identified, let's say we used any screening tool or any type of other screening tool that lets us know that somebody tested positive. Once we identify this patient, what would be the next step?
Yeah, so for children, we'd want to determine if and or what help or interventions may be needed. If there is a disclosure or finding suspicious for some form of maltreatment, so physical abuse, emotional abuse, sexual abuse, then of course that falls within the realm of making a report and fulfilling that legal mandate. And if there is a concern for co-occurring, since we were just talking about domestic violence, if there's also a concern for co-occurring domestic violence, you want to make sure that you convey that when you're making the report, so that those who are responding to the situation are informed about that possibility. because we know that things can escalate as it relates to domestic violence when authorities become involved or there's kind of that initial outcry. And we don't want to put anyone in further jeopardy. And so we want to make sure that that information is conveyed. Certainly, you know, there's the intervention side of things to disrupt the abuse, but then there is also managing the impact, which may require mental health care that is trauma specific and trauma responsive. And then for adults, you know, if there's a, I don't want to say positive screen because I've just told you why I don't agree with using it in that purpose, but if the conversation about ACEs yields some positive experiences, then to ask, did you ever get help for that? Is the follow-up question. You know, we're not just asking the questions or assessing to check off boxes or to say, okay, well, this patient is more likely to have X, Y, or Z, or that explains why they have X, Y, or Z. No, there's more to it than that. And so, you know, you can ask, is there anything that we can do to be helpful? And that's knowing that we can't fix everything. We can create, as I said earlier, safe spaces, and we can provide and direct patients to resources that are kind of beyond the scope of our practices. And fortunately, you know, there are a number of resources that are available in our community that can help adults and children cultivate resilience and get beyond what happened to them so that they can be you know, fully, so that their resilience can be fully manifested.
Thank you. Yeah, it's definitely very important that wherever we're working at our specialty, that we have that social support for patients and we're able to direct them to those resources. And programs like Healthy Steps that can help those new parents kind of get through those maybe difficult first stages, right when the kids are 0 to 3 years old. But are there any other resources that you think may be required prior to, you know, maybe in an office setting, fully implementing any type of screening or conversation as we're talking for ACE?
Yeah, so I mean, I think the first step is to be prepared for the patients who've experienced adversity in their childhood, or even for that matter, you know, right now. And so clinically, of course, we want to follow the patient's lead in exams. And there goes the siren. You know, and so we have to prepare ourselves for practicing maybe outside of our norm, and recognizing that some patients may need a supportive individual, and maybe we're not used to that in the way that we normally or typically practice. Some patients may require more time for their visit. You know, it may be a lengthier visit to walk them through the steps of, you know, a pelvic exam, for example. And so maybe that has to take, you know, be built into the scheduling for that specific patient. And then we have to recognize we can't do it all as physicians. So team with, you know, your staff. If you have a social worker on your team or a psychologist on your team, of course, your nursing support, so that you can be proactive in establishing a process and a plan for those assessments of adversity that are positive, so that you all know you can become kind of like a well-oiled machine in terms of how you will respond, and, you know, almost like a code. You know, everybody has a responsibility around the patient, right? Same here. How can we create that same kind of response in our clinical settings, so that the burden doesn't fall all on the doc, knowing that the doc can't handle it all by themselves, but we can together help our patients.
Perfect. And kind of speaking about implementation, having everybody being on board and prepared for this, any thoughts of how it could be incorporated into different specialties, such as maybe community centers versus private offices, or as we were discussing before, different specialties?
Yeah, I love this question because, you know, in all honesty, I think some providers may presume that ACEs are not relevant for their patient population or their specialty. And that is why I kind of led with giving some of the background of the original ACEs. We can get in the habit of profiling our patients, right, for who's more likely to have ACEs and who's less likely. And we are really doing a disservice for those who don't fit our profile. Because the truth is that ACEs happen everywhere, across cultures, across economic levels, in all communities. And so I don't think there is any setting where ACEs assessing and having ACE conversations would not fit. And so I think it's important for us to be universal across specialties even, because you may just be that provider that they feel most comfortable with sharing something that they've never told anybody else. And so if you're a cardiologist and they tell you this, you want to be prepared to be able to respond. I think about cardiology, not on purpose, but if we walk through kind of the steps of what a patient might have when they go see a cardiologist, well, they might have an EKG done. And somebody's going to put leads on part of their body that could be a triggering experience for them. And so even in a setting like that, it may be certainly quite relevant. And so I don't think your work setting really makes a difference. I think the conversation is something that should be had everywhere.
Thank you. Yeah, I agree with you. I think as primary care, sometimes, we're expected to do so much and with so little time, right? And it's important that in this conversation, we include, like you said, everybody across the board so that we can all really have plans implemented to help when we identify these patients, what we can do for them, or at least if not, connect back with the primary care who maybe has a little bit more resources just to kind of help place the patient where they need to be and get them what they need. So kind of circling back then, what do you really feel is the ideal use of this tool?
So currently, I think the ideal use of the ACE screening tool is for epidemiologic, public health, and research purposes. However, elements of the tool can be a great guide to inform the ACE conversations that we need to be having with our patients.
And any interventions that you feel that have been shown to help ameliorate some of that toxic stress? I know
Sure.
we talked about a little bit of resilience factors, but anything else that kind of has come up?
Yeah, so kind of the resiliency factors are things outside of our practice, what are happening, the things that are happening in the lives of our patients. But in the clinical setting, there are some interventions. Trauma-focused cognitive behavioral therapy is really, I think, the leading evidence-based treatment intervention, although there are certainly other promising practices of mental health interventions that help to ameliorate the impact of toxic stress and trauma. So some of those promising practices or evidence-supported interventions are things like something called EMDR, which stands for eye movement desensitization and reprocessing, mindfulness, and trauma yoga. I think, and I'm fortunate to work, I'm not a mental health professional, but I am fortunate to work with a team of individuals who are mental health professionals. And what I've come to understand is this increasing acknowledgement of the connection between the mind and body. And I think in traditional medicine, we're finally getting there. But I think in the mental health space, they are kind of beat us to the punch there. I should not use punch. I'm trying to avoid violent terms. Beat us to the game. And so things like trauma yoga is not something that, as a pediatrician, I would never know anything about that. But I think we are increasingly aware of some of the kind of non-traditional or non-Western interventions that help people manage their feelings and their thoughts and their reactions to their experiences. And the truth is that for any given patient, one treatment modality may not be sufficient, particularly if their trauma is complex. And so when we as medical providers are referring patients to mental health professionals based on new knowledge of prior trauma, we want to make sure that we're referring them to places that actually treat trauma. Every therapist doesn't treat trauma. And so the blind referrals may really not be helpful to the patient. And the other part of that is, again, think Maslow's hierarchy here. If basic needs and safety are not met, our best intentions to help and a patient's desire to heal may not be effective. They may not be in a position to meaningfully engage in mental health care services if those basic needs are met. And so, we need to be asking questions about those things so that our patients can kind of reach the pinnacle of success for them.
Well, Allison, those were all the questions for today. Thank you so much for this conversation. I definitely learned a lot, and I think it's very important that we start having, again, kind of bringing this awareness and talking about how even if we may not be at the point of using ACE screenings officially, that importance of talking with patients about, their trauma, trying to understand them at a better, trying to understand them where they're at so we can provide those resources, get them connected to what they need, and also hopefully at least establish a better relationship with them so they feel more open to us. And again, that's going to impact so much of their health with helping them become more adherent with their medications or with the care that they need, or open to even just having certain interventions being done. So thank you so much for your time today. It was really an honor to talk to you and to have this conversation.
Oh, it's been my pleasure. Thank you for the opportunity to chat with you as well, Gisela.